This video will be about HIVs. I've gone through past Mrcog, SBA question and also Mrcog. There's not much of questions about HIV, but one of it questions about the family of the virus, and then about the infant testing regime for those who actually takes formula milks and also who is breastfeeding. So basically that's, and also one of the probably complications of the AIDS, which includes the Kaposi and also the pneumocystic carinine pneumonia. Okay, so let's begin the HIVs. So as we know, HIVs is coming from the Lentiviridea family, and it's from the Retroviridae. So if we look through this is just my imaginations of the viral structure, but in general it is an RNA composed two single-stranded RNA inside, in which inside it's composed of protein P24. We have P24 here, and also P17. And what it does is actually it attacks mainly the T helper cell 2, which actually the CD4 with CD4 molecules. Apart from T helper 2, it's also attacked the dendritic cells and also the macrophages. So it's attacked dendritic, which usually will goes to the lymph nodes and cause the lymphadenopathy. All of this composed of CD4 molecules on the surface. So what molecules it is? Let's zoom in into the molecules. The CD4 composed of the glycoprotein 120, and the virus loves the glycoprotein 120 very much. And on T helper 2, there is a co-receptor that called CXCR4, while the other co-receptor, this also contain GP120, but the co-receptor is different, whereby the co-receptor for the dendritic cells and also the macro is CCR5. So that is why in looking at the severity of the disease, we count the CD4 count itself. CD4 cells over the millimeter power of 3. Okay, so what it does is that once it invades the cells through the co-receptor here, so from the single-stranded, they use the retrotranscriptase and forming a DNA. This DNA can actually invade the host cell, and it will bind to the host DNA after using the reverse transcriptase. And what makes condition worse is when the CD4, the T helper, usually they will, if there is some infections ongoing, the T helper will call for help from other dendritics and also macrophages. But in the case of the infections with the retrovirus, the T helper will then replicate the virus, the RNA virus, due to the infections. So that is why when we look through a graph, we can see if we can divide it into acute and also a chronic phase of infections. So this usually 12 weeks, and the chronic phase can be from 2 years up to 10 years depending on the progressions of the disease. So what you can see here, let's color the virus in pink. So usually the virus, initially when it's invade the host, it will increase in the number, and while the CD4 count will slowly reduce. But then since the body tried to work out and combat the virus, they will start to increase a bit of the CD4 count, and the virus starts to reduce. As once the patients get into a chronic phase, the virus will slowly increase, and the patient will start to develop the complications with AIDS, and the CD4 count will slowly reduce. This is CD4, and this is the viral load. That is what happens usually. So how do we test? So usually when the patients start to have let's talk about the prevalence first. So the prevalence what is prevalent? It's an incident of the HIV in the populations. So the prevalence in UK, because we are studying Mrcog, is 2 in 1,000. And this actually, the prevalence is different between England and London, with the England prevalence is higher as compared to London. And as you can see, if the HIV is actually can be transmitted through sexual intercourse, and in sexual intercourse, there are 75% of cases due to the sex, and the 25% before the presence of the heart, the retroviral therapy, is due to the MTCT, which is the mother-to-child transmission. And in the sexual intercourse, it is differs from male to male and male to female. And in fact, from female to male is lesser. 0.08% of risk of transmission of one intercourse from male to male, while 0.04 from female to male. And then we have what we call, I don't want to call it, but it's anal sex and also oral sex also contribute to this percentage. In Mrcog part 2, they're going to ask about the percentage. For example, receive anal, how many percent? It's a count about 1.1%. If the insertive anal, so it's going to be 0.06. If receive vagina, it's 0.1%. So it's actually lower than the anal. So insertive vagina is 0.082%. And then in blood transfusions, if you have a blood transfusions and also needle prick injury account very low percentage. But if the patients get infected from was transfused with the HIV infected blood, then the risk of transmission is very high, about 80 to 100%. And while the IVDU, I don't have a percentage here, how many percent, but the IVDU account about 0.6% of the infection. Okay, so that's for the prevalence. And then what I want to talk about is about the symptoms that the patient started to have in response to the CD4 count. So if we have a CD4 count 200 to 500, and if the CD4 count even worse, less than 200 per millimeter power of 3. So what happened if the patient have such count? The patients first usually will have lymphadenopathy, because the dendritic cells usually will go to the lymph nodes, and then the patient will start to have hairy leukoplakia, which usually can be seen in EBV infections. There's a whitish discolorations on the tongue, and usually the patients also will experience oral fungal or oral candidiasis. In severe case, on the other hand, the patient, if the count is less than 200, then the patient will start to have from the HIV symptoms, or patient will develop AIDS deficiencies. So the patient will start to have a persistent fever, diarrhea, and loss of weight, sometimes more than 10 kgs. And then the patient will start to have fatigue. So it's a very non-specific kind of presentations, but this is due to, one, the patient start to have a recurrent bacterial pneumonia. Specifically, we talk about the pneumocystic carinii pneumonia with a typical lung features on the x-ray, and then the fungal infections. And previously it's only in the oral, but fungal infections can also go to the esophagus. And then the patients will start to have other infections, co-infection, like Kaposi sarcoma, which due to the herpes group 8, and also primary lymphoma of the brain, and cause a death. And this actually 52% of infants who had HIV usually will die within 2 years of life. Continue to the next video.